Pulsed wave Doppler measurement of E-wave forward flow of blood through the mitral valve from a left apical four-chamber view can be used to identify severe mitral insufficiency. This is one of the most important cardiac ultrasound measurements to determine current or impending congestive heart failure. Normal maximum E-wave mitral flow is 60 to 90 centimeters per second, or 0.6 to 0.9 meters per second. Mild and moderate insufficiencies will have a normal mitral E-wave maximum flow. E-wave maximum flow exceeding 120 centimeters per second, or 1.2 meters per second, indicates a severe mitral insufficiency and the presence of congestive heart failure or increased risk of congestive heart failure. In some cases of current severe congestive heart failure, pulsed-wave Doppler may top out and show excessive but inaccurate maximum flow of the mitral E-wave. Continuous wave Doppler may be needed to accurately measure a severely elevated maximum E-wave forward flow through the mitral valve. Mitral E-wave deceleration time is the time it takes for maximum or peak E-wave velocity to return to the baseline, or zero velocity. Normal mitral E-wave deceleration time for dogs is 80 to 100 milliseconds. In mitral regurgitation, more than half of the total stroke volume that should be going forward through the aortic valve may be ejected retrograde into the left atrium, leading to early closure of the mitral valve and a short deceleration time. Values less than 80 milliseconds suggest severe mitral insufficiency and poor survival. This animal is in congestive heart failure and shows severe elevation of mitral E-wave forward flow, but deceleration time is 110 milliseconds. Deceleration time depends heavily on heart rate and will be short with rapid heart rates and some arrhythmias. Deceleration time should not be used alone to stage mitral valve disease. The isovolumic relaxation time is an optional cardiac measurement that can be made from a left apical five-chamber view. It is the period of time between the closure of the aortic valve after left ventricular systole and the opening of the mitral valve. During this time period, both valves are closed and left ventricular pressure drops rapidly from approximately 120 millimeters of mercury to 5 millimeters of mercury as the left ventricle relaxes without a change in left ventricular volume. In mitral insufficiency, the left ventricular volume is actually changing because of the mitral leak, so it is not a true isovolumic time measure. The measurement can be made using pulsed wave or continuous wave Doppler. With continuous wave Doppler, the cursor is placed in the left ventricular outflow tract or aorta. When activated, there is typically a downward aortic flow followed by a valve snap as the aortic valve closes. This is followed by a valve snap as the mitral valve opens, and then the mitral E-wave. Sometimes the mitral opening valve snap is not seen. The measurement is made by placing a cursor at the end of the aortic valve snap and the beginning of the mitral valve snap, or the beginning of the mitral E wave if the mitral valve snap is not seen. One or both valve snaps are not seen with every heartbeat. Use cinematic loop to look for the best image. With pulsed wave Doppler, the pulsed wave gate is widened or open to its largest width, about 6 millimeters. The pulsed wave gate is placed in the aorta or left ventricular outflow tract. Activate pulsed wave Doppler and look for the best image. The normal IVRT is about 45 to 73 milliseconds. In dogs with congestive heart failure, elevated left atrial pressure causes the mitral valve to open early, shortening the IVRT. In dogs with mitral insufficiency, a measurement of 45 milliseconds or less suggests congestive heart failure and a poor prognosis. The IVRT is highly dependent on the patient's heart rate and should not be used alone. Rapid heart rates cause a short IVRT. To make the IVRT more useful, the maximum mitral E-wave velocity in centimeters is divided by the IVRT in milliseconds to get a ratio. Ratios greater than 2.5 indicate current congestive heart failure or increased risk of congestive heart failure. Of course, a high E-wave velocity will result in a high E to IVRT ratio. Mild mitral insufficiency is not associated with pulmonary hypertension, but elevated left atrial pressure associated with moderate or severe mitral insufficiency can cause secondary pulmonary hypertension. If tricuspid insufficiency is present, the pressure gradient of the tricuspid insufficiency, taken from a left apical 5-chamber view, can be used to prove the presence of pulmonary hypertension. A peak tricuspid regurgitant velocity of 2.8 meters per second or higher is considered abnormal and indicative of pulmonary hypertension. Pulmonary hypertension in dogs is considered mild with right ventricular to right atrial pressure gradients of less than 50. Moderate is 51 to 75, and severe greater than 75 millimeters of mercury. The use of pressure gradient alone has been reported to predict pulmonary hypertension accurately. Estimated right ventricular or pulmonary artery pressure greater than 40 millimeters of mercury is suspected to represent more than left heart failure alone. The presence of moderate to severe pulmonary hypertension in dogs with mitral insufficiency is a reason to begin treatment of the mitral insufficiency. Treatment of the mitral insufficiency should reduce the pulmonary hypertension.